I am Dr. Jyotsna, Professor of Cardiology working in Nizam's Institute of Medical Sciences. Today, we are planning to do a webinar on changing practices in women in CAD management. Why we have taken this topic is, as we already know, there is increasing incidence of the coronary artery disease in both men and women. National Statistics Survey Organization NSSO survey is the largest one, which is demonstrating the increasing the incidence of the coronary artery disease. According to this, about 3% of the rural population and 7% of the urban population are suffering with the coronary artery disease, and which is steadily increasing. According to the WHO report in 2014, the age-adjusted cardiovascular disease mortality rates in India were 349 and 265 per 1 lakh in men and women respectively. Not only that, there is increase in the mortality also. Steadily from 1990 to 2030 is gradually increasing, which was reported about 20.6% deaths in 1990 to increase to 29% in 2030. So, as we already know that increased incidence is occurred in both the male and the females, but about 2 decades back, the major difference in the gender was demonstrated. Females were underdiagnosed and undertreated. But in the Western world, after the red campaigning, which causes the increased awareness of the detection of the coronary artery disease in the female, caused the decrease in the discrepancy of this gender. We wanted to see in our country. Mainly, we have taken the data of the coronary angiograms and PCAs done in our institution. Our institution is a large center, tertiary care center, where we do more than 3,000 angiograms and more than 1,500 PCAs annually. So we divided this coronary angiogram data and PCA data into 2 decades. That is from 1998 to 2008 as a first decade, and 2009 to 2018 as a second decade. So in the first decade, the 1998 to 2008, we can see that a steady increase of the CAZs done was seen both in men and women. Of course, proportionately in the men it is more than in the female. In 1998, the female angiograms are mounting about 300, and whereas in 2008 it is increased nearly to the 900. If you divide this first decade into a group of the 5 years from 1993 to 98 and 98 to 2003 and so on, and we have seen the incidence of the severity of the coronary artery disease in the normal coronaries. The first bar is representing the normal coronaries, and subsequent bars are representing the single vessel, triple vessel, double vessel, and significant coronary artery disease. So there is an increase in the severity of the coronary artery disease as the years are progressing. In addition, the normal coronaries are also increasing in the proportion. For females, it is important, as we know, that prognosis is bad even though he has normal coronary if the presentation is acute coronary syndrome. Similarly, from the 2009 and to the 2018, annually, if you see that there is a steady increase in the females undergoing the coronary angiograms. Almost it is looking like a starting in the case of the males. Similarly, if you take the PTCI data into the 2 decades in the similar classification of the first and second decade, in the second decade from the 2009 to 2018, there is an increase in the number of the PCA done in the females, gradually increasing. But in the males, almost with a slight fluctuations in the peaking in between 2012, but almost it is troughs and increments are seen. Again, in the similar way, if you divide into the 5 years into the one group, in 1998, The PTCAs done in females were nearly about a 50, which is increased to nearly 300 in 2008. Now I'll present 2018 NIMS data of the angiogram and PTCA, mainly to concentrate on the change in the route which was practiced over the years, and as well as the changing the coronary risk factors. So the root of the angio, if you take only the 2018 data, about 27% of the cases only it was done through the femoral, whereas the majority of the cases it is done through the radial. After the angiogram, nearly 42% of the patients require medical management. This medical management includes not only the normal coronary angiograms, but even the diffuse coronary artery disease. And 58% require the revascularization, either a PCI or CABG. Females are constituting about 33% of the whole of the population who are undergoing an angiogram, and the peak age group in females is between 50 to 70 years who are coming for an angiogram, followed by 35 to 50 years. If you see what are the risk factors, hypertension is constituting a major risk factor for coronary artery disease, followed with diabetes. Of course, smoking and alcoholism are the incidence is little bit less in our South Indian populations. And dyslipidemias, family history of the coronary artery disease is already known cases of as a risk factors. But one of the important features which are occurring as the years are going on is the history of the previous coronary artery disease. So many of them are the recurrent coronary artery events. So also they have an underlying left ventricular dysfunction. If you take the diabetic patients from the 2007 to the 2018, then almost there is an increment is occurred. But if you see this increment from the 4.1 to the 55.7 is occurred is about the 2012. The sudden transition is occurred with the 2011 to 2012. And if you see the age-wise distribution and the diabetes, the peak diabetes is occurred in females between 60 to 65 years, and which is almost a static up to the 80 years, and then started slightly decreasing the tendency. Similarly, the hypertension also, there is an increment of the hypertension occurred, but a sudden step up is occurred from the 2008 to the 59.3% in the 2011. Almost a 1 year earlier, it is occurred than that of the diabetes. Other important risk factors which are not very important in the first decade but become much more important in the second decade are the renal insufficiency. Many of them are having an underlying renal insufficiency, of course, increasing the weight, which is in the form of the defines as the obesity, and respiratory problems. Nearly 0.3% of the cases, the respiratory disease has becoming important. This may be in the form of COPD, bronchial asthma, or interstitial lung disease, or the respiratory tract infections. Previously, the explanations for the COPD patients to have the coronary artery disease is mainly because the same risk factors are the common for the coronary artery disease in the COPD, like smoking and age. If you keep aside these two, still these people are the much more prone for the development of the coronary artery disease. Similarly, as we already know, other peripheral vascular diseases, either in the manifestation of the cerebrovascular accident or the limb ischemias, these people are the much more likely to have the coronary artery disease. But nowadays, we are seeing a few of the cases, the DVT demonstrating the coronary artery disease. This is whether the venous thrombosis will predispose the arterial thrombosis requires a special evaluation, despite of the age group, which may be a predisposing for both the DVT and coronary artery disease, even in the younger age group who are presenting the DVT mainly because of the traumas, even there we are able to see the coronary artery disease. So we can say that the recent emerging risk factors are the respiratory diseases along with the infections and the DVTs also. And the type of the presentation of the coronary artery is mainly as a chronic stable angina in 64% and 36% are presented as a acute coronary syndromes. As I already mentioned previously, as the hypertension diabetes incidence is increasing and recurrent coronary artery disease is becoming a more frequent, we are seeing a more commonly than LV left ventricular dysfunctions. And in 29% of the cases, already the patient has a severe LV dysfunctions. If you draw a bar diagram of the distribution of the LV dysfunction from the 2007 to 2018, there is an increment is occurred about the 2011 and is almost persisting at the higher level up to the 2018. So nowadays we can say that from the chronic stable angina acute coronary syndrome stage, now the coronary artery disease is complicated with an LV dysfunction in addition. Majority of the PCIs as in angiograms are done through the radial routes. And the PCI of in the females and males, if you compare whether it is done through the femoral or radial, it is shown that definitely gradual increase of the radial is occurred, and the majority of the cases nowadays is done through the radial route. Even in the females, the radial route is much more frequently done than in the males. And majority of them has a single vessel disease. But if you see the multi-vessel disease, almost from the 2007 to the 2018, this is the proportion, 30.7% of the 27 population versus 30.8% of the 2018 population. So the multi-vessel disease is almost not much of altered over a decade. So what is the conclusions we can draw from this data? Conclusion 1. Rate of rise in the patients undergoing the invasive procedure with the CAD. In patients, both males and females, undergoing the invasive procedure for CAD detection, that is coronary angiogram, was increased. But the rate of rise in the patients undergoing invasive procedure for CAD was more in the females than in the males. So if you see this rate of rise in the first decade in the male is about 10.85% versus in the female is 21.45%. In the second decade, it is 1.11% in the male, and whereas in the females, it is 5.36%. This means to say that this is not just because the increased incidence is more in the females than in the male. This is because more females are accepting to come to invasive procedures. Proportionate rate, even though the absolute number of the invasive procedures increase is seen in the females, but a proportionate rate of rise was more in the males. The proportionate rise in the first decade in the males is 16.4% versus 15% in the females, whereas in the second decade is 6.57% versus 3.6%. This means to say the rate of rise of the patients who are coming with invasive procedure is increased, not due to the absolute increase in the number. This is much more increase in the incidence is reflecting the more males are coming. But that is not true that the more females are really coming. That means to say that more females are accepting, but not up to the proportion of rate of rise of incidence in the general population. Means there is still some gender gap is persisting. It is not gone completely. If you take the data of the PCI who are accepting to come for the coronary revascularization also, that is true. The rate of rise is more in the females than in the males. In the males, the rate of rise in the last decade was 46.36%, whereas in the females is 35%. whereas in the next decade, the rise in the males is about 1.1% versus the 15%. If you take the rate, the proportionate increase, like in the coronary angiogram, even the absolute numbers seems to be the more in the females, but the proportionate increase is more in the males than in the females. So with this we can say that the discrepancy is decreasing in between the genders as the more females are coming for the diagnosis of the coronary, angiograms, so that coronary artery detection is increasing, and more number of females are accepting to coming for the revascularization, so the PCA number is increasing, but it is not similar to the rate of rise in the general population versus the similar to the rate of rise in the male population. Similarly, if we take the risk factors, we have already seen previously that diabetes is increased from the 4 to 53.5% in the 2008 to 2018. So the sudden transition is occurred between the 2010 to 2012. Whereas the hypertension also similarly is occurred, which is constituting a 15.4% to 72%, and which is occurred about 1 or 2 years earlier than that of the transition zone. If you see this in diagram, you can see this is the hypertension histogram, this is the diabetes and histogram in the patients who came for the angiogram. It says that the hypertension is occurring 1 or 2 years earlier than that of the hypertension. Hypertension is occurring 1 or 2 years earlier than that of the diabetes. So other emerging risk factors are like a respiratory disease, infections, and the DVTs are contributing factors. Thank you very much for your attention. So I conclude to say that it is increased, the discrepancy in the gender is decreasing, and newer emerging risk factors we are able to find both in the men and the women.